Good morning, good afternoon, and good evening. I'm Mukta Sandhu, Senior Scientific Education Manager representing Geistlich Pharma, Switzerland. Today's webinar topic is timing for the grafting and implant placement after the extraction by Professor Polido. As we all know, the decision making process regarding the timings and technique must be decided before the tooth is removed to optimize the outcomes. Upon completion of this presentation, I'm sure all our participants should be able to understand the biological effect of tooth extraction and recognize the different moments for implant placement, and also the bone and soft tissue relationship to the extraction. I must assure you all today that today's speaker is a great teacher and the best orator. So we are very lucky to have him on board today. A little bit about Professor Polido, who is an oral and maxillofacial surgeon with a master in surgery and PhD degree from Porto Brazil. Professor Polido also did his residency in oral and maxillofacial surgery in University of Texas. He is an active ITI fellow and speaker lecturing extensively worldwide, and he collaborates frequently with Osteoscience Foundation and as a reviewer for the main journal of oromaxillofacial surgery and implantology. Professor Polido currently holds a position as a clinical professor of oromaxillofacial surgery at Indiana University School of Dentistry. And also, he is a co-director of the Center of Implant and Aesthetic and Innovative Dentistry there. So before I hand over to our speaker, few tips to make this webinar very interesting and interactive. Please write down your questions in the question section and we will address them at the end of the webinar. And if you have any technical difficulties, also write to us that my colleague Artem Raskatov will guide you through. So thank you for being here with us. And Professor, the stage is all yours.
Thank you for the nice introduction. It is a pleasure to collaborate with this webinar about the timing for extraction, implant placement, and grafting for the aesthetic zone. So we will discuss a few topics related to this clinical need. Let's say all of you, if this patient shows up to your office next day, tomorrow morning, what are you going to do? How are you going to plan it? What are the steps that are necessary to achieve a good outcome? So you may be thinking several options. Do I do an immediate implant or do I do a late kind of implant? Do I use what kind of implant design, implant diameter, platform switch, implant related characteristics? Do you do it flap or flapless? Do you have to use a bone graft, autogenous, a bone substitute, a membrane? What kind of bone substitute? Where is your donor area for your autogenous? Do you need a soft tissue graft or maybe a soft tissue substitute? Do you do immediate loading? How are you going to decide in just a matter of minutes, how are you going to best treat your patient? So those are all very important aspects. Or maybe you do a socket grafting for ridge preservation and place the implant sometime later in the future. All those things you have to think, or you do an early implant placement with guided bone generation, then you have to make the same decision as far as kind of implant, kind of bone graft, how to do it, how to manage soft tissue. Very, very many different things that we have to think about. So what do you have to think before you want to do the implant? You have to think about timing. Do you do it immediate? Do you do it early? Do you do it late? You have to think about the implant selection, the macro, the micro, the surface, the connection, the abutments. You have to think about bone graft materials, bone and soft tissue kind of graft. What are you using? How do you manage it? When do you apply it? And then obviously you have to talk about loading protocols, immediate, conventional, custom healing abutments, anatomical healing abutments. All those options have to be considered. So you can do an extraction with an implant and a bone graft. You can do just extraction and a graft, so-called bridge preservation. You can do an implant and a bone graft at the same time in a early kind of a position with the GBR, guided bone generation. And then you can also have no implant, just a graft, extraction, wait, graft, wait, and then finally put an implant. All these are evidence-based uh, options that you can decide and apply according to your patient. So the key is what do you have to check before deciding. So obviously you have to always check for soft tissue because that's the first thing we see. Before even getting an x-ray, you should do a clinical examination for your patient. Recession, quality, condition, stability. Then you have to look at bone, anatomy, quality, quantity. That's when your CBCT comes in and you look at all those aspects that we're used to when we do implant related treatments. So we will discuss a little bit on alveolar bone healing, alveolar bone changes after extraction, imaging, implant characteristics, implant position, then finally augmentation and the timing to do all these things, the implant and augmentation. So there are a lot of papers on the alveolar bone healing. Here are some of the references, but if you one of my favorite because it's very clinically oriented is this one by Araújo and co-workers on alveolar socket healing. What can we learn? So he taught us that a relatively thin buccal wall in the anterior maxilla characterizes the alveolar socket and provides support for the outline of the buccal aspect of the alveolar process. This buccal bone, no matter how you do your extraction, minimally invasive, will eventually be resorbed. And then, as you see on the illustrations on the bottom of the slide, the soft tissue will collapse, creating a ridge defect, which tends to increase with time. So we have to find ways to support that tissue with our implants and grafting materials. So just the immediate placement of an implant does not prevent buccal bone loss. Grafting, yes, limits the collapse of the soft tissues and at the same time supports bone formation. So preservation of the ridge dimension will occur as a compensatory mechanism for buccal bone loss. And we as clinicians should take clinical steps to enhance that area to allow reconstruction, implant placement, but also to mimetize that the tissues stay where they should stay, supporting that potential collapse that can happen. So here you see different healing moments of the same anterior maxilla. One that is very wide and rich, one that is very narrow, very thin, the other one that was grafted, and the other one where nothing was done and it has so much resorption that you cannot really put an implant in. You have to do a staged graft healing. So make sure when you get proper imaging that you use a nice technique. You use what we call a Smiley lip retractor or an opticate, what some sort of a lip retractor to reflect the noise of the lip out of the way. So you see exactly the soft tissue thickness on the anterior and the palatal part of the maxilla. And you see the ridge dimension in height and in width, however you want to do it. And you can use that also to measure the follow-up to see where your implant is positioned and how the graft is being held. This is another really good study that shows using that imaging technique that on the anterior maxilla, on average, bone is less than a millimeter at 1, 3, and 5 millimeters height from the cervical margin. So we have to be aware that we can anchor our implant in ideal, like you see in this CBCT on the screen, nice wide apical bone, putting the implant in the ideal restoratively driven position, but we have to support the soft tissues on the most coronal part of that socket. And then this is another paper by Vivienne Chapuis, Professor Boozer from Bern, showing that there are different kinds of bone loss in that central portion of the most coronal aspect of the socket. And you see in red where different configurations of defect may happen. Small V, a big U, a big vertical defect. And that is related to the patient's phenotype, but also related to how you do your extraction. Try to be as less traumatic as possible. But even if you do that, the cause of the tooth loss also influences how inflammation, bone remodels, and that can affect soft tissues and bone on the facial portion of that socket more than the usual. This is a recent paper, again, by Araújo and co-workers that shows exactly the anatomical characteristics of the alveolar process and basal bone that have an effect on socket healing. So he looked at quantity of socket walls, quality of socket walls, sagittal root position, the tooth angulation inside buccal palatal, inside the alveolar ridge, and available basal bone. So if we scroll through this table, you see the quantity of sockets in a cross-sectional, but also in an axial position. We usually looked at the cross-sectionals only, so get used to look at an axial position of the bone configuration and the alveolar bone and the root inside before you even extract it. You see on the first one, a lot of bone, 4 intact walls. On the second one, you have 3 intact walls. On the third one option, you have complete bone loss. And if you scroll up, and I'll share this PDF with you at the end, you'll see the quality of socket walls, how they are thick or thin, the tooth angulation in relation to basal bone, so they can be more forward, more palatal or tilted, and the basal bone in relation to the alveolar process. We may have a big, wide basal bone that favors vascular supply to our implant and bone graft, but we may have very thin hourglass shaped and where the tooth is outside of the alveolar bone process that may actually complicate or bring more risks and challenges to our treatment. So you see here the root length, but the proximity to the nasal floor or the sinus is actually the apical portion of that basal bone that says the root position inside or outside the alveolar bone, and how having big, wide, thick bone is a lot easier than having very narrow or hourglass shaped bone. Obviously, you have to look at proximity to anatomical structures like the incisor canal, the labial plate, the sinuses, the apical portion, of course, of the nasal floor. So you have to understand the thickness of the labial plate, but also the labial defect configuration, as we mentioned, to understand how that is going to impact your implant position. And you see where the tooth is inside the alveolar bone, you have a safer zone in green that is better. And the more outside of the alveolar bone or the more resorption you have around bone, around the tooth in the alveolar bone, you go into a danger zone. So you have to assess that as well before you even think about doing an immediate implant. So the use a little bit also is when you have these challenging situations, is a lot easier to manage it with an implant diameter that has reduced measurements. So reduced diameter implant is recommended because you see here, if you do a wider implant, you have very thin bone. You already have thin bone to begin with. So if you use a narrower diameter, like you see here in the dark gray, there's just more bone around it. You preserve more bone. But not only that, you have a larger gap that will improve vascular supply for your bone graft and your soft tissue graft. So nowadays, the use of reduced diameter implant, 3.3, 3.5, no larger than 375, allow you for optimal with platform switch emergence profile, but also allows you to create space to put the graft to support those tissues like we mentioned before. Obviously, you need to place the implant in the ideal position, buccal palatal to be a screw retained, but also on the vertical 3 to 4 millimeters apical to the cervical margin, prospected cervical margin of your future crown. So always prosthetically driven implant position. And if you have a missing bone, you have to graft around it. That is a very important concept. Not only graft buccal palatal, but also mesial distal. So we have to understand where is the ideal position you see in green and what are the danger zone. You do not really want to go into the danger zone. Now, another important thing is the place implant a bit deeper because we know that if you choose a narrower abutment and that is a bit taller or longer, we'll have more bone preserved around that implant. So if you see on those three color reddish orange kind of implants, you see on the middle one, there's actually a wider implant, but with a very narrow and tall abutment, preserving bone. This is a study done by Gary Finell and Galucci and also Mauricio Araújo and others to the Harvard group that shows that narrower implants with long and narrow helium buttons will actually preserve more bone. So that's an important concept also. So in summary, we now know that horizontal augmentation is always necessary. It's not almost, it is always necessary. That's been proven time and time again for several authors. And I'll show you this case to illustrate this concept. Both patients you see on the screen are my patients treated many years ago. One you see a result that is not that ideal. You see a little grayish area by transparency on the gingiva. You see recession. And the other one on the lateral incisor, you see a almost perfect outcome. So how did I manage those things differently? That one I did not really understand, and now the other one I do understand what needs to be done. Both are basically different brands, but same kind of implants. So it's not implant brand related. Both are narrower implants. Both are external hexagon, butt joint connection, screw retained crown. So both have that same saucer-like defect on the most coronal that is usual with this design of implant. Now, when you start looking at the occlusal view, you see that the one with the less than ideal outcome, and that one is probably that photo taken more than 10 years after the implant was placed, you have a concavity. So by having a concavity, you have less horizontal support for the soft tissues. Whereas in the other one, where you have a better outcome, you have a convexity. So the implants are on the same position, buccal palatal. It's just that one that you see big, wide bone, we graft around it with bone and soft tissue. So that is the main difference. And that is the clear reason why we need to graft those cases right off the bat when we place the implant in. So you see here, if we look at CBCT now, you see on this one that there's just implant and no buccal plate at all. When I placed the implant, there were no exposed threads. I thought that was good. So we did not have the knowledge that we have now. Whereas in this one, even if the implant is in the same position, ideally placed, I actually ended up grafting just to support the tissues. And you see that more red opaque area that is grafted, and I just doing an effect. If I had that same graft on the other side, I would probably have the same outcome. To always graft those implants in the anterior zone, especially in the 1 through 6 or 7 millimeters coronal to it, and more towards the center where usually the defects are. So let's illustrate some clinical situations. This is a really good recent paper by Cardaropoli, Mariam Neves, and Paulo Casentini, published in 2021, where they were very smart into classify that in 4 types. And you see here that those are tied into a previous paper by Paulo Casentini, also with Matteo Chiapasco, on how do you place the implant and you graft it. So you see a type 1 where you can put the implant in and almost no graft or minimal intra-socket grafting. You can have a situation number 2 where you put the implant in and you have good bone and you just need to do a soft tissue grafting. You see number 3 situation where you have the implant in, maybe some exposed threads or very thin bone where you have to do a bone grafting. Plus, and the last situation is where you can put the implant in and you have to do a bone grafting plus a soft tissue grafting. So let's look at clinical situations where those things apply. And then we have the worst cases where we cannot even do anything. We have to do what we call class 3 and 4 Chiapasco, which are the staged grafting. You have to do just a vertical or horizontal, sorry, just a horizontal staged grafting. And you have to do a staged horizontal and vertical grafting, reconstructing the alveolar bone to later then in another stage put the implant in. So class 1 is when you have everything optimal, optimal condition, optimal bone, optimal soft tissue. You can anchor your implant in the ideal position. There is no inflammation, good bone, good soft tissue. So obviously for that, the number 1 choice will be an immediate implant placement with potentially an immediate loading or an immediate temporary. And you have to graft that little gap that stays on the buck of your implant, place it on the ideal position. Now, as a second option, if you're not risking to do an immediate implants or for whatever reason you do not want to do an immediate implant, you can do a ridge preservation. Ridge preservation is never a problem. And you also have, even in an ideal situation, the chance of going with an early or type 2 implant placement. You take the tooth out, you do nothing, you wait 2 months, soft tissue is nice, you will open a flap, put the implant in, do your graft, and everything is good. But when you have a class 1, immediate is probably the way to go because you can optimize your outcomes in just one procedure. So let's take a look at the type 1 or immediate placement situation. How do we manage? And that is the case I started the presentation with. And I like to do a risk assessment. If you scan this QR code, it's going to take you to the website where we created this straightforward advanced complex classification in implant dentistry, where you see this patient and you look at a lot of aspects. You look at bone, you look at soft tissue aspects. And in a webinar, you can stop, pause, go back and take a look at all these details and tie that to the QR code I just showed. But you see that in this situation, the high risk, the red column is very low. And that means we have more green, a bit yellow, and almost no red. That means the risk is low for an immediate implant placement. All the factors are controlled. And you look at the aesthetic risk factors, you also see some yellow, but most green and not a lot of red. So the high risk is not present on this case. So clinicians with some experience, moderate experience, can probably have a good outcome on a situation like that. That is why we chose to do it immediate. Very carefully, minimally traumatic tooth extraction, sectioned if needed. This case is actually published on Dr. Kademani Tijuana Atlas of Automaxillofacial Surgery. If you want to look at that in detail, just go to that book, Implants in the Aesthetic Zone, that I published with Dean Morton. So now the tooth is out, the implant is in, and that gap is grafted with DBBM plus collagen, demineralized bovine bone matrix plus collagen. So we see the gap, and this is exaggerating on the sagittal slice on the drawing just to show that you need a gap and you need to have space to fill that graft with a low substitute resorption uh, rate for that case. And then vertically, you place that implant at 3 to 4 millimeters apical to the prospective gingival margin. Nowadays, the recommendation that you do it fully guided if you can, static fully guided to make sure it's perfect. I always like to use, like you see here, a shaped with the crown margin to see where that is. So I have the fully guided and also I have the uh, vertical position well corrected. And then you play with your implants to make sure that you have ideal torque. This is measuring the torque greater than 35 Newton centimeters, your RFA, your ISQ greater than 70, and then you have the subjective opinion of the clinician we like to measure. So if you can achieve anything above 7, you can probably do immediate loading. Back to our case, implant is in, good primary stability, a low substitution rate by material, DBM plus collagen is in the socket, and now what you have to do is maintain the soft tissue contours. And how do you maintain that? Well, you can have an immediate temporary crown where you adjust the margins perfectly to seal that socket, and you can take it out of occlusion. But you can also have an anatomical healing abutment that helps to maintain that socket. So here, a lot of attention to the emergency profile. So you do not want to overextend it, and you do not want to underextend it. Also, the subcritical and critical areas need to be perfectly matched. So you see on the two bottom photos that the papilla is actually with a little bit of a contraction. The moment you slide the temporary crowning, it helps to support and bring that papilla back to the place. And the patient leaves with a tooth in place. You can take it slightly out of occlusion. Very compliant patients. Patient selection is also critical. And then you follow up. This is 3 to 4 months later, nothing to do. You just unscrew that crown, scan, copy that emergence profile, and make sure you do the all around cosmetic dentistry in all the adjacent teeth for this situation was needed. So then all the crowns match it, and we have a very good and long lasting outcome. And this is a 4-year follow up. This is done by a colleague of mine from Brazil, Dr. Dudu Pitas do Canto. And you see here how nice that is even after a long term follow up. So an immediate implant placement has the advantage of just having one surgical procedure. It's patient friendly. They prefer that. But I have to say that if the conditions are not ideal, then do not even risk it because the complications may be very, very high. So if you do not have experience, if you do not have the socket, the side morphology is not good, thin tissue phenotype, potential lack of keratinized mucosa, infection, any of those issues, just do not do it. It is a technique sensitive procedure. You need to have some experience. Ideally, you want to do it in a flapless fashion. So you need to have done more surgeries. Nowadays, with the fully guided, it's a bit more controlled. And it may be also hard to place your bone graft in the ideal position through a socket and not through a flap. Now, class 2 on this classification is when you have actually good soft tissue, but there's no bone. There's no bone to put your implant in. And you can subtract nowadays with the AI and digital technology the tooth out of your CBCT, and you simulate and you say, well, I do not really have a lot of options because once I took that tooth out and correct the socket, I will have minimal bone, less than 4 millimeters or 5 to anchor the apex of my implant. So what are the options here? The number one option in this situation would be the ridge preservation, I think. And that's according to this paper by the authors. So if you take the tooth out and do nothing, bone may resorb or remodel so much because of the pre-existing bone loss that you may not be able to put the implant in. And then you're setting your case up to do a staged bone graft. Whereas if you do a socket grafting or ridge preservation procedure and a delayed implant placement, you wait 6 to 8 months, you may be able to put an implant in with minor additional grafting. Some situations are prone to an early approach too, if you feel you can anchor the implant, but if more dramatic cases, I would definitely go for ridge preservation, which is the go-to and relatively easy. So when do you indicate those? When you cannot put implant in, growing patients, patients like a teenager, 14 years old, loses the central incisor, you cannot put an immediate implant in. So you have to graft that socket, wait for them to grow, use some sort of a temporary crown. When you have a lot of different teeth that you need to change, the static design is not ideal. You do not want to lose bone. You put that the patients in orthodontic treatment where you're changing the prosthetic space. You can do it ridge preservation, soft tissue deficiencies, pontics, and sometimes financial issues. You do a procedure that costs less, and you graft the socket, and you wait, and then you put the implant in, and then you wait, and then you finally do the crown. So a ridge preservation is what we call an intentionally late implant placement. You graft the socket and you wait 6 to 8 months, depending on the graft material you use, and then to finally put your implant in. So let's see this situation where the patient came with a indication for extraction of the maxillary right central incisor, and then you see there is almost no bone around it. She had adjacent teeth that had crowns prep, so we had a good stable temporary. And the plan was actually do that. So you see again on the SAC classification, we see more red, we see high risk, and then we see yellow, and then we do not see a lot of green. So you zoom in your screens wherever you're watching that, and you just read that, and you read through the QR code I showed you to go in details how that's done. And then here the static risk assessment again, a few greens, but again a lot of yellows and some reds. So it's a moderate to high risk for this situation. So here we prepared the two adjacent teeth because they were all restored and they had previous crowns. That made it easier. And we will extract the central incisor. And you see there's no bone around it. There's buccal plate loss, and there's almost no bone on the apical and palatal portion. So we take the tooth out, and you will see here that we are carefully using periotomes and extracting the tooth. And I can just speed up a little bit for the sake of time. So now you carefully see how the tooth is being extracted. We section it, and with a minimally traumatic forceps, removed the root tips, pushed that in, trying to not even touch the buccal plate. Now you see the socket, and we will curette all that tissue, inflammatory tissue from it. And as we curate, after that, we're now creating a little pouch or a pocket, apical, a subperiosteal pocket without opening a flap, apical, mesial, and distal, to where the buccal plate loss is. So we create a little pouch, and you'll see why, because that buccal plate we will reconstruct with a collagen membrane. So we will use a double layer collagen membrane and rest that apically, medially, and laterally on that pouch that we just created. So you see here now that we are creating that. And then once that is done, take your time, be patient. You see the membrane with a tiny instrument being positioned. And this is subperiosteally being sliding in apically, mesially, distally. So that membrane will become our new buccal plate. This is nothing new. This is the classic inverted isochrome technique by Dr. Taro and Ilian. So we just use, the materials are more refined nowadays. So we have that. Once that is in, keep a little lid open. So you will rotate and close that over the socket. So you see here now that the membrane is in. And now we have the demineralized bovine bone matrix plus collagen. We shaped it a little bit. It is actually dry. You may put a couple of drops of blood, and holding the membrane, we will put the material in. So that's the pre-op. Here's the membrane. Now we're putting the collagen, and everything is going in. And now you pushed it with a small plugger. Make sure to really compact that into the socket and keep the membrane in, because the next step after that is in, you will flip that collagen membrane and tuck it into the palate. This is done in a flapless fashion, so you're reconstructing. Do you always need that membrane? Well, no. If you have not a lot of bone loss in the buccal, less than what we're seeing here, then you probably do not need a membrane. But when you do have a lot of buccal loss, but good palatal, mesial, distal, you can use this technique for that same purpose. So you see in here, we are going to fold back that and protect that socket. So at this point, you can use a soft tissue graft from the tuberosity, or you can use a soft tissue substitute in a round form, 12 millimeters, to seal that socket. Or you may just use the Pontic also as a no void Pontic to seal that socket. So it depends on the case. If your soft tissue is very thin, the phenotype is thin, then you may want to actually use a soft tissue graft, autogenous, from the palate, from the tuberosity is actually my favorite. Take a wedge out of tuberosity, and you can also use a soft tissue substitute if you don't want to, if you do not want to harvest, or if the patient is hard to harvest. So now this is completely grafted, and you make sure this is subgingival, and you seal that socket with the bone material. So here you see that 6 months later, you see a nice wide socket that now allows you to put an implant in a flapless approach, and maybe doing a minor soft tissue graft, because you see there is a bit of a flattening still on that buccal plate. But you see here a before and after how just being patient and waiting, we were able to reconstruct that socket. So now the goal was achieved, and we can now do a fully guided flapless implant placement, still creating a little pouch, and we graft that buccal with a soft tissue to bulk even more that buccal plate. You see, it's a narrow implant, and that is placed deeply enough to create the immersed profile. So once that is done, we wait for osseointegration, no immediate loading, and this is a ceramic abutment that is screw retained, and the crown is held on over that. And this is the final single tooth. Of course, the adjacent teeth were restored as well. So let's follow into the class 3 now. Class 3 is when you do have even decent bone, but you do not have any buccal wall, and you have soft tissue resorption. You see in this situation here that you have a lot of soft tissue resorption. The central incisors are going to be extracted and replaced with an implant, and they have the cervical margin so high that we cannot think about doing an immediate implant in. But there's actually decent bone. So in those situations when bone is favored, when soft tissue has inflammation, recession, then the ideal option is not even do ridge preservation, and obviously not do an immediate implant, but do a early implant placement, Professor Boozer's type 2 early approach with GBR. What you do is you just take the tooth out, clean it, maybe put a collar plug on it, something collagen plug, something that resorbs faster and helps to bulk the soft tissue, and you wait 8 to 12 weeks. After 8 to 12 weeks, you have a lot more soft tissue. And then you have to open a flap. You're seeing what you're doing. You're putting your implant in the ideal position. And then you're grafting around it. You're doing classic GBR. Dr. Boozer has taught us that and proven time and time again that this works in long term. So there's a lot of evidence for this approach. And this is one of his best papers that 10-year follow-up using this technique. So let's see a situation where we combine all these approaches. This is a situation where this patient had loss of the central and lateral incisor, and we decided just to take the teeth out, let it heal, open the flap. We have, this is not fully guided, and we place 2 implants in the ideal position. And now you see you have exposed threads in a concavity. So this is the classic early type of approach. So here we decided to use a combination of a bone substitute plus PRF, autogenous PRF. We're using a centrifuge with the patient's own blood. So you see PRF liquid being applied to the bone graft. It works better when you do allograft fibers and PRF, but you can also use PRF with a xenograft. So it becomes what we call a sticky bone. And then once that sticky bone is placed, autogenous first scraped from the area, the anterior nasal spine or the lateral maxillary wall, or the ramus if you want to, you protect the exposed threads with autogenous chips. Over that, you put the bone grafting with the PRF liquid, and then finally you cover everything with the PRF gel. So now you're doing a gel, PRF gel, over the bone graft, and then you see here is the membrane, collagen membrane, double layered or the thick one. And then on top of that, you put another layer of PRF because that helps the soft tissue healing. Obviously, I don't have to explain that. You have to have excellent soft tissue management skills because you need to now close your flap over all this area. So here what we're doing is we're closing everything over, and then we wait for that to heal. Once it heals initially, nice healing, you can start reforming the with ovoid pontics where the implant emerge profile needs to go. And then you finally expose, and you may have to do another soft tissue graft. Sometimes you do, sometimes you don't. This patient had a good phenotype. And then we create the emerge profile and finally deliver two single crowns for this patient with the classic approach. So PRF may be used with grafts. It works well with allograft. It works well with xenograft. It works well for sinus grafts, which is not the topic of the lecture today. But it helps xenograft to integrate faster and better. It helps soft tissue management. So it is an autogenous kind of a bone enhancement graft that works really well with both allograft and xenograft, depending on your material of preference. Now, the advantage of an early placement is that number one, you have an increased area of soft tissue. You have more soft tissue. Take the tooth out, you clean the area, you're dealing with a very healthy area, and it's reduced treatment time if you compare to ridge preservation because you do not have to wait 6 months. You wait 2 months, maybe three, that's it. Bone will probably be the same, a little bit of flattening, but soft tissue will be much better. And there's no more pathology associated with the tooth loss. Now, the disadvantages are obvious. One, you need to wait 3 months. Two, you need to open a flap. And three, you need to have a bit more experience to do it. But again, agreeing with Professor Boozer's approach, this is actually less difficult than doing a flapless immediate implant placement. So if you're not that experienced, this may be the good way to go. Take the tooth out, let it heal, open a flap, you see where your implant is going, you know exactly where that goes, you're looking at placing your graft. Your graft is the same, you're just doing now with an open flap. So it requires an adjunctive procedure, but you are actually looking in detail where everything needs to go. A class 4 is a severely compromised case where there's not a lot of anything, no bone, no soft tissue. So those are where it's personal preference. It depends on your lab expertise. You can just extract, wait anywhere from 4 to 8 weeks, and attempt to put an implant in and do GBR. You can extract and do grafting, and then wait, and then see if when you open a flap, you need to do another GBR when you do ridge preservation, or you may just have to wait, take the tooth out, and deal with a staged bone graft augmentation, Capasulas class 4 and 5, and deal with that. So let's see here a combination case. So this is not that new of a case, but it combines everything we're talking about here. Patient has missing teeth on the upper left and on the upper right, but also will lose a lateral incisor. So on the maxillary right side, we're placing two implants for a 3-unit bridge, first premolar and first molar, and we are reflecting the palate, and we are bulking the ridge out on the buccal, grafting with autogenous connective tissue from the palate because we had that flap open anyway. So it's a lot easier just to harvest autogenous connective tissue. So you see here, the day of placement, 1 week, 3 weeks, but you can see on the palate that we had to thin that tissue to harvest the graft, no perforations, but it's still, that is in healing. But we were able to create a nice thick buccal tissue on that area. So, and that is the final restoration after 6 months for that patient right side. Now, on the same patient, on the same day, actually, on the left side, we did an extraction of the lateral incisor because it was fractured, and we had to do an immediate implant on the lateral incisor on the left, leaving the gap, grafting the gap with the BBM plus collagen. You see the implants on the posterior area as well, where we had a concavity and the two implants on the ideal position. So for this situation, we actually use a DBBM plus collagen to graft on that buccal and enhance the soft tissue, completely closed with a soft tissue substitute. So we did not have to harvest more tissue from the palate. And then we were able to close everything nicely and leave it's a one stage, all the implants had really good primary stability. So you see the implants, BBM plus collagen around the implants, and then on the pontic, we just used a soft tissue substitute to bulk the tissue out. And here you see both sides at 1 week, at 2 weeks, and then finally at 2 months. And you see how the outcome on the buccal is pretty much the same. But you can see just by looking at slides that where we had to do autogenous harvesting of the soft tissue, the post-op for the patient was not that easy. Patient never complained about the soft tissue substitute side. They complain about the palate harvesting the graft from the left side. So you see here surgery fine in about a week. And then you see now the left side 3 weeks, 6 weeks, 3 months, and 6 months with the soft tissue substitute. So what you see here is a pre-op photo of the model, the cast, before everything, and then the final outcome, especially pay attention to the concavity on the buccal that was fully supported with the BBM plus collagen plus the soft tissue substitute. So take to work message. And then we used to say take home message, but take you don't want to take this home. Home, you take a gift to your, to your wife, to your husband, to your kids. But when you are at home, probably watching this, so you want to take to work message. Number one, PRF can be used with allografts for faster remodeling and long-term maintenance. PDGF works better with allografts. PDGF is not effective with xenografts. So if you use xenografts, you may go PRF. If you do use allografts, maybe PDGF will help, so you don't have to use PRF. But PRF is the one that combines both with better with both. Treatment planning for implant therapy should start once the tooth extraction indication has been confirmed. Get a proper CBCT before extraction and go through all these details that we talked about. Both implant placement loading protocol and grafting protocols should be planned prior to tooth extraction. This was published in 2018. Selection of the implant placement, grafting materials, and restoration should be evidence-based to achieve predictable outcomes, long-term stability, optimal aesthetics, reduced risks for complications, reduced risk for future periimplantitis, and obviously poor static outcomes. You want to make sure your implant is integrated in the right position with a lot of bone and soft tissue around it. So, a little decision tree. Extraction, immediate placement, extraction, implant placement, and graft. You know you have to do those three, and you tell your patient, tooth needs to come out, implant needs to go in, bone and or soft tissue needs to be placed. Now, how do you do, when do you do what? When do you do what? That's the critical point. So you do your SAC classification, your risk assessment, like we talked about, and then you ask yourself these questions. How is my aesthetic risk? What are the soft tissue level and condition of that site? What is the alveolar bone anatomy, facial bone, interradicular bone, alveolar bone, adjacent teeth? How is the basal bone? Everything we showed on this presentation. Then you say, okay, can I put my implant in the ideal position? Do I do it guided? I recommend you do it fully guided. How is going to be the implant primary stability? Can I have space to do my augmentation? Can I do it flapless? Do I have experience or the team that I work has experience with it? If everything is yes, then you want to do an immediate implant placement. Fill the gap, put a temporary crown like I showed. That is probably the number one indication for immediate placement. There is a lot of benefits, and if you can control the risks and the risks are not that high, you can do it. Now, if one of those things or more is a no, then you have two choices. Choice one, you take your tooth out, put nothing on the socket or a collagen plug, something that resorbs faster, and 8 to 12 weeks later, you do an early placement. You open a flap and you do a GBR. Now, the other option here is you do a ridge preservation. You take the tooth out carefully, no flap. You pack that socket with your biomaterial of your preference. I like xenograft, but you pack it and then you wait. So you see the two options. So option one, immediate, already has the implant. Now let's see what happens to options two and three. If you did ridge preservation, you have to wait at least 6 months, minimum 5, 6 to 8 sometimes, depending on how you graft it. Now, if you, and then you see that image and then you plan your implant. Now, if you did just a collagen plug on it and you have to wait now around 8 weeks, so at 8 weeks, you very likely will have minimum flattening or even a concavity. You get your CBCT, there is a buccal defect. And now what you have to do is you, both situations, one is 6 months later, one is 2 months later. You go through the same questions. You do your risk assessment step by step. You go look at the absolutely same things: static risk assessment, soft tissue level, condition, alveolar bone anatomy, facial bone, everything in detail, basal bone, and you ask the same questions. Can I put my implant on the ideal position using a guided approach with great primary stability, space for augmentation? What kind of augmentation do you need now? Just soft tissue, maybe a big bone and soft tissue. And then do you have experience to do it? Most cases in the Bridge preservation may even be able to do it flapless if it's just a small soft tissue. But on the early, you have to open a flap. So if everything is yes, you do an implant, maybe a soft tissue or a connective tissue graft if necessary, and you're done. But sometimes that is not ideal. So you have to do your implant plus GBR plus a connective tissue graft if necessary, the early approach, right? Now, if you do not do any of this and just wait the socket to heal, you may end up with this situation where there's nothing to do other than a staged graft augmentation. So that is for another day, another topic, another webinar. There's a lot of really good webinars on this platform on staged graft augmentation, horizontal and or vertical, where you can choose from autogenous to titanium mesh. Nowadays, we have custom CAD-CAM, custom titanium meshes that you can fill with the biomaterial of your preference. You have non-resorb titanium reinforced membranes, and we have autogenous blocks. Those are the three main techniques for staged bone grafts. So I want to thank you for your attention. And if you need any more information, number one, you see here my Instagram and the Instagram for our department at Indiana University Automaxillofacial Surgery. And if you scan the QR code, it's going to take you to a Dropbox folder where you can read the PDFs of all the papers I cited during this presentation. So I'd like to thank, of course, my team. This is the IUSD Implant Center team, Dr. Morton, Dr. Lin. I'm in the center, Dr. Dutra and Dr. Yang. And also thank my oral maxillofacial surgery team of residents and colleagues, faculty, and amazing staff for the support and all the hard work we put together to allow me to create this kind of presentation. Thank you.